Hello, everybody, and welcome to Locator Lunch. Good morning to those on the West Coast, and good afternoon to everyone like myself on the East Coast. I'd like to welcome you to our 15-minute Locator Lunch, where we're learning everything about locators. I'm Amy Helayel, Global Education Manager for Zest Dental Solution, and I'm very honored today to have an amazing guest. Chris Concepcion from Arklign Dental Laboratory in San Jose, California, is going to be joining us today. So welcome, Chris. I'd like to welcome you to Locator Lunch.
Thank you, Amy. Thanks for the intro.
Absolutely. Thank you for joining us. So why don't you just real quick, give a quick introduction and tell us a little bit about yourself.
Sure. Christopher Concepcion. I'm the technical director for Arklign Laboratory. Been in the dental industry for about 30 years. Worked for Straumann, worked for Astra, worked for Brasseler, worked for 3MSB. Kind of helped launch the Lava, the first zirconia out there. Then all together came back to my good buddies of mine at Arklign. They started growing, and I started helping them grow. And we've been growing quite substantially with Locator Fixed.
So, as you know, you're such an amazing partner of ours, and I was just honored to have you join us today. So, being that you are the lab technician that we go to for a lot of our question and answers, we get a lot of questions from doctors. And I just wanted to talk today about what you could do to help some of our audience, some of our doctors that are online watching, some of our technicians that might not be aware of how to get started with Locator Fix. They've heard about Locator Fix. They're interested in Locator Fixed full arch therapy, but it's, now what do they do? How do they connect the pieces and get started working with a laboratory?
Yeah, I think the biggest hurdle right now is that the locator abutment is the same locator. A lot of doctors are talking about Locator Fix. So what armamentarium do I need now? I'm like, you don't need much of anything. You just need the housing and the insert. Those are the only two things you really need different. A lot of doctors think that the locator is different. It has to be a fixed locator abutment, but it's the same. Once we talk about that, I would say it's pretty seamless. At Arklign, what we try to do is make everything lab-driven. We don't want the doctors to think about anything or measure anything because mistakes happen. I can measure better in the laboratory on the model that impression that is sent. So what I do for my laboratory digital workflow is scan the patient, do scan bodies, take a PVS, take a fixture level impression. And that's how our workflow at Arklign works, is just take a fixture level impression and you could do Locator Fixed. Take a fixture level impression and you could do overdentures. All the way up to the final stage is denture 101, right? So I'm giving him an impression, I'm giving him a wax try-in, I'm giving him a teeth try-in. At the final stage, we convert it to a Locator Fixed. But along the way, I give them Legos to put in the mouth to make sure it fits, to make sure that transition line is not seen when the patient smiles. And then at the final stage, we give them Locator Fixed completed. It's very seamless. It's not much hurdle. And doctors that I've converted from fixed hybrid to Locator Fixed, they're like, this is amazing. I had a few doctors crying, like, I was so scared to do Locator at first, but since you explained it, since you coached me along the way, you made it so easy because she's done the AOX before. And we all been there.
Yep, absolutely.
It's a long chairside appointment. When I send one of our technicians out to do a conversion, it's a 4-hour appointment. With Locator Fixed, you don't have that. It's a denture 101 all the way to final. So basically 4 appointments the analog way. And then at the final, we give you the locators. Doctor screws them in, torques them in. It's a pickup. The doctor has to pick it up chairside. We provide them a jig so you can get the orientation because we recess. So everything is floating in the mouth a little bit, 0.5 diameter and 1 millimeter on the occlusal space. We use a scan body. It's a perfect recess for the housing of a Locator Fixed. I've seen some instances where the recess is just so big because they make it passive, but it's too passive.
Right,
and we get prosthesis, right? So we use the scan body to recess the entirety of that prosthesis, and it's the perfect geometry enough for chairside to be picked up. It's basically I tell them a little dollop on the housing, 2/3 of the way up on the recess holes, and it's probably hardly anything to clean up. So when they snap it in, the blacks are in there, they switch it to the fixed, and they're done. I
Now,
would say
digital scanning. What about for those analog doctors that aren't ready to do digital? I know you talked about scan bodies. So
yeah.
what can you tell about, if a doctor's just doing analog right now?
Yeah, analog, you would just basically, I asked doctors, have you taken an impression of a single implant? They're like, yeah, of course I've done a single. I said, times 4. Open tray or a closed tray if they're parallel. You make that decision. All it is an impression, fixture level impression times 4. They squirted that impression material like they would for a single, send it to me, and that's all they need to do. Put the healing abutments back in. I pour up the model. The next, like I said earlier, is denture 101. They're going to get a wax rim. We recess over the healing abutments so the doctor can fit it in like a denture. It'll have the flanges. The upper will have the flanges in the palate, and it fits like snug like a denture. They don't do anything. They don't snap anything until the final stage. So everything's recessed over the wax, over the teeth. At the final, we give them it recessed. They screw the locators in, and they're done. When I do these 2-3 hour lectures with hands-on, doctors are like, why am I so worried about measuring? Like, I know you're worried about measuring because it's hard to measure in the mouth, right? It's hard to give me the right height. And I also tell them, and you usually order one you think's the right one. You order the one that's taller, and you order the one that may be shorter. You order 3 for one site. So what I do is I help them with their inventory, right? So they don't have to have a handful of locators at time of chair side when they're putting these in just in case, because the patient's in the chair. I give them already measured on the model. And what I do extra is I put the housings on top of the locators, because if you have different tissue heights, you kind of really have to put the housings on top to see if you have enough space. And I would say 1.5 to 2 normally than would you do for an overdenture, I say is key for fixed. So it's pretty seamless. It's overdenture, you can say 101, and they're switching it to fixed. It's a simple process. I can't believe it's a revolutionary product. I can't believe more people don't do it. I'm traveling all over the country, preaching about the locator fix. And when I do, the eyes just open up.
It is. It's such an amazing system. And I wish everyone understood how easy it is and how simple it is and how effective it is for, our patients, offering them a great fixed full arch solution.
Yes. Yes.
So
go ahead, Amy.
Go ahead. I'm sorry, Chris.
No, go ahead.
So I'm just looking at a couple questions that are coming in to ask. And the one of them, which you answered already about digital and analog. Another one coming in is material. So a lot of questions on what material, Chris, would you recommend for a locator fixed prosthesis?
Yeah. So in my lectures, I always say, don't tell me what material you want. I said, let me pour it up. Let me evaluate the case. Let the mouth dictate the restoration, right? If we have 8 millimeters of VDO, and this is always the hurdle where we get stuck is a VDO. If you give me 8, you can't have a monolithic zirconia. Here's what you're going to get. If the patient agrees to it, is a bar with a locator with a zirconia on top of the bar. Anything with metal, just remember these 2 numbers, is 8. Anything without a metal bar is 10. So if the patient gives me 10 millimeters of VDO, I'm like, you can have all of them because you gave me enough VDO. But your restriction is the cantilever. If you're doing a nano with Trilar, I can't have 15 millimeters cantilever. If it's a Bruxer, I can't give you to second molar. So it's all about the communication with the doctor in the laboratory on the parameters of what you can get. Some doctors will say, void the warranty. And I always say a lab can do anything. I can do a fixed locator with 4 millimeters of VDO, but will it last? No. And this is the reason why we communicate with each other and tell you what I see and what parameters of material that I can give you. That's going to be a long-lasting restoration for the patient. So we have these checks and balances. I always talk about pivotals. If you look in the webinar, the hour webinar we have in the ZES, it talks about everything we look for. I have a whole team that looks for every acronym of pivotals, comes to my desk, I evaluate it, talk to the doctor talks to the patient, and then we make the final decision. in lab huddle. So to make it successful, materials all work. Locator fix definitely works, but you have to really be strict on the parameters of what the mouth presents and what the material can allow. Those are I would say, the two things you really have to abide by for it to be successful.
And that's a great point. I talk about that as well. It's about the patient, and it's about what that, recipe you need to make the successful case. So that's an excellent point. Chris, I had a question come up about the housings, and someone talked about or asked a question about the overdenture housings versus a locator fixed housings, and what's the difference, and can you use them both interchangeably?
Well, with a locator fixed housings, you can't put a overdenture insert in those, right? So what you have to remember, I've been in the lab for quite some time in ERA. So basically an overdenture with a regular, we call a legacy, they pivot inside the housings, right? Where this fix is actually fixed and nothing pivots in the housing. It's a PEEK material, very rigid. It does not pivot. Overdenture for what you would call tissue supported, it's not. Locator fix is implant supported. You don't have flanges, you don't have a palate. So it is strictly implant supported. So that's the big difference.
What is the minimum implants you recommend for a locator fixed prosthesis?
So we've been doing 4 on the upper, 4 on the lower. But if implants do fail on the upper, sometimes they do that. We've done locator fixed with 3. We've been doing it with a few doctors in Texas. It's been working. They just put up the retention a little bit higher and try to spread those 3 as much as they can, depending on the bone, right? We have to look for the anatomy. We have to look for landmarks. But we do get away with it with 3. We definitely get away with 3 for overdenture. The difference is that we leave a little palate, because the way we do it in our lab, our overdentures have a cast metal frame in it. So it has the strength and you don't have a palate the patient can taste. But if it happens to be 3, we leave a little palate for a little bit more retention.
So you brought up a point about, the inserts again and that black processing. One of the big parts of making sure this case is successful is trying in proper aesthetics, proper speech. With the fixed inserts, obviously you're not going to be putting that in and out. What's the best method for a doctor once they get a case from the lab and they're trying it in? Just kind of explain a little bit more about the black processing inserts and how that works to the doctor's advantage to make sure you have a successful case.
Correct. So I always tell the doctors, the blacks are like training wheels for the patient to kind of hone in on how to put it in, how to bullseye it to where the locators are. It's kind of a like I say, training wheels or a training ground for the patient to try to put that in for at least, 2 weeks and then change them out, right? So the black ones are processing for the lab. I can put the real ones in, the PEEK or the plastic, but I have a lot of doctors that say, just leave the black, that's clinical. Let me see what the patient can handle and just give me the black inserts when you deliver the case.
Absolutely. So with our last minute or so, I wanted our audience to take away, if they're considering locator fixed, they've heard about it, they've read about it, but just not sure what the next step is. What would you recommend for a doctor or clinician that's heard about locator fixed, possibly has some patients in mind that are maybe in those overdentures that want to have a fixed prosthesis,
right?
A little bit nervous, not sure what to do. What do you recommend is their next step?
I would say give me a call, because every doctor is different. It's just like our laboratory. We have thousands of active clients, and I always tell them, we're not making a crown, we're making your crown, because a different crown same crown for another doctor is different. So everyone has their nuances, their preferences, is which I call them. Give me a call, go on to our website, look into our help menu, and there's a lot of good information on there from the palm of your hands. I would say go on learnlocator.com. There's a lot of information there. Our social media has a lot. We post every day. It has a lot of information on locator fix. And, zestdent.com. Go on there. But give me a call, because, I'm also a Zest believer.
You are a Zest believer. Chris, you are an absolute amazing partner of ours. We look We love working with you and all of the education that you do for clinicians around the country and helping patients around the country. So I wanted to thank everybody for joining us this morning and this afternoon for our 15-minute locator lunch. On the screen, you have Chris's email and phone number to reach out with any questions on learning locator fixed or any case questions. We also have to visit zestdent.com, which also has, like the webinar Chris was talking about. We have our webinars on our Zest Academy for our education, information on locator fixed, information on how to get started working with locator fixed. I highly recommend you visit both of our websites to see what we can do to help your patients. So with that said, I'd like to thank you very much, Chris, for your time with us this morning and this afternoon for myself here on the East Coast. And thank you, everybody, for joining us this morning and afternoon. And we look forward to seeing you next time on Locator Lunch.
Thanks, everyone.
Thank you.